Hi everyone, I am Dr.Jyotsna. I will be talking about patient ventilator asynchrony. So, what is patient ventilator asynchrony and what is relevance in clinical scenario? Whenever we put a patient on ventilator, there will be interaction between the patient and the ventilator. And if ventilator is not doing what patient wants or it is not meeting the patient demands, suppose the patient is taking breath inhaling and ventilator is trying to opening the exhalation valve and trying to let the patient exhale, or if the patient wants to exhale it out and that time patient is giving a positive breath, that means there is a difference in the interaction between the patient and the ventilator. So there is a asynchrony between these two. So that will not be helpful for the patient. And why we are putting the patient on ventilator? To support the breathing, to support the patient. So we need to synchronize the ventilator to work according to the patient's needs, and that if that doesn't happen, that is asynchrony. And what is this relevance? The patient will be in distress, it will be nightmare for the patient, there will be ventilator induced lungs injury, it will be difficult to wean a patient, there will be prolonged ICU stay, and there will be poor outcome. To understand the concept of asynchrony, you need to understand trigger, limit, and cycling. And for that, please go and see my other videos on triggers, limit, and cycle. What are the type of asynchrony? We can divide asynchrony into three types. One which is during inspiration, and another is flow asynchrony, and one is cyclic, which you can say as expiratory phase. It's asynchrony during the expiratory phase. Trigger asynchrony is basically there are four different types. One is ineffective trigger, reverse trigger, delayed trigger, and auto trigger. Cyclic asynchrony, which occurs when the patient is between the inspiration to expiration, when it is this phase, which is called cycling phase. That time, if there is a delay in cycling or there is early cycling, that is called premature cycle, that can cause asynchrony again. So let's start with ineffective trigger. What is ineffective trigger? Whenever a patient wants to take a breath, if a ventilator doesn't support the breath, suppose the patient is like here, you can see these are ineffective trigger. So when a patient want to take a breath and ventilator doesn't understand that okay, patient is triggering a breath and I have to support that breath with a positive pressure, then that is called ineffective trigger. What is the cause? So cause is either there is a problem with the patient or the problem with the ventilator setting. So if the problem with the patient, what could it be? There could be weakness of the muscles. Maybe we have the paralytic or the sedative has not been weaned off. Maybe the patient nutrition, there is deficiency in the nutrition, there is dyslipidemia, or because of the decreased respiratory drive, maybe because of the uh, sedation which we have given to the patient, or because of some stroke or some CNS dysfunction. So or if other than that, what about the ventilator part which could be contributing to the ineffective trigger? Are suppose a patient has um, sub, we have set a trigger sensitivity of 3, and patient has triggered a breath of, like, patient has triggered the breath, but he was not able to overcome this -3 sensitivity, means pressure. He was not able to generate a negative pressure of -3, and instead of that he has only generated a negative pressure of 1. So it means he has not triggered the breath, and once he will not touch that threshold point of -3, the ventilator will not understand that okay, my patient is taking a breath and he should give a positive breath. So this is called ineffective trigger. And so what we can do is, what are the solution for this? The solution is that we should minimize the if we want to wean ineffective, we don't want that there should be ineffective trigger. We need to minimize the paralytics, we need to minimize the sedations, give optimum nutrition. see for the dyslipidemia like hypokalemia, hypophosphatemia. We need to change the trigger sensitivity according to the patient's demand. So if the patient is not able to trigger generally -2 to +2 is good enough, and generally patient is able to trigger. If he is not able to trigger -2, we can put it to -1. Or flow trigger is easier for a patient than the pressure trigger, so we can change this to a flow trigger. Or we can use newer ventilators like Nava, uh, which can take up the diaphragmatic electric activity, and accordingly the ventilator can give a positive breath. And we should also think about the auto PEEP. What happens when the patient is triggering a breath? It has to overcome a auto PEEP if there any. So we need to take care of that also. If there is any auto PEEP, we need to correct that. So these are the negative deflation in the pressure time scaler. And if this deflation doesn't touches the trigger point, as you can see here, it is touching the trigger point, so breath has been generated. And here it is not touching the this point, it is not touching the triggering threshold, so this is not converting to a positive breath. So this type of graphic you will see in ineffective trigger. So now comes to reverse trigger. What is reverse trigger? Reverse trigger is whenever a passive breath is given, the passive breath may cause diaphragmatic stimulation because of stretch of the diaphragm and its receptors, which may trigger another breath. So reverse trigger is always followed by a passive breath. So here this is this is the active breath, means patient is taking the breath. So after this, if the another breath is double trigger, another breath is happening, that will be called double trigger. And you can see here, this is a patient passive breath. This is a passive breath. After that, if the second stimulus, second positive breath is going on, this is called reverse trigger. So we have to minimize sedation so that passive breath doesn't occur, and in this way we can minimize or fix the reverse trigger. So as I have told you, we need to differentiate reverse trigger from the double trigger. So reverse trigger will be followed by passive breath, and double trigger will be followed by active breath. So and double trigger is because of the premature cycling. This is reverse trigger. This one is reverse trigger. This is a passive breath. After that, another patient ventilator is trying to exhale, and another second breath has been triggered because of the stretching of the receptors in the diaphragm because of its over distension. And here you can see this is a negative breath, patient triggered breath. This one is patient trigger breath. So after patient trigger breath, if another breath is taken, this is called double trigger. This is basically because although the ventilator inspiratory time has finished, but the patient inspirated still want to take inspiration. So he has his because of which the another breath you can see here. So this is double trigger or early premature cycling, it is called, and this is called reverse trigger. So auto trigger means neither patient is taking a breath nor ventilator is giving the breath on its own. uh, it is not means when although ventilator is giving, but the ventilator is not giving according to the set breath. When generally we set a breath of, like, suppose 15 breath per minute, 20 breath per minute, or 10 breath per minute, we set on the ventilator, or either patient takes a breath. If the patient is taking the breath, you can see it as a negative deflation pressure time scalar. And if the ventilator is if If it is number of breath is more than the ventilator set breath, and it is neither a negative deflation, that is patient trigger breath, then that is called auto trigger. And the cause of auto trigger is generally it is because of the condensate in the circuit, or there is some leak, or the sensitivity patients, that trigger sensitivity has been set so low, is so sensitive, so high sensitivity, that even a small vibration like cardiac oscillations may trigger a breath. So generally passive breath of greater than 3 consecutive passive breath is required to make a diagnosis of auto trigger. So these are the auto trigger. This is a passive breath, and this was not a patient trigger breath, neither ventilator set breath. So this can be fixed by checking for the any yes, suction. We have to suction. We have to check for leak. If there is any nebulizer, if there is any condensate, or if sometimes you can see that the respiratory rate is around 80 or 70, or it is matching with the uh, cardiac monitor. You can see that if there is a ECG graph, if it is 70 per minute heart rate is going on, and there you may see that respiratory rate is also on ventilator. You may see respiratory rate is also going on that 70 per minute. So or it may match with the arterial line waveform. So those you need to see. Flow asynchrony. What is flow asynchrony? Suppose a patient or flow starvation. So what happens in flow asynchrony? When the patient flow demand is not met by ventilator, then flow dysynchrony occur. How it looks on ventilator? In ventilator, the flow asynchrony will look like this. This is a pressure time scalar. There will be a inspiratory limb. There will be a scooping. So scooping according to the level of starvation, flow starvation. It can be divided into mild, moderate, and severe. If it is more less than scooping is less than 50% of the baseline, it is called mild. If it is greater than 54% of baseline, it is called moderate. And if it is below baseline, it is called severe flow asynchrony. So if there is asynchrony, the cause of asynchrony is basically when the ventilator is not able to meet the patient flow demand. So it could be because of the low tidal volume, or low flow respiratory rate, a low flow rate, or maybe slow rise because of that. The solution is that we need to increase the in volume control mode, we need to increase the volume, or in pressure control mode we have to increase the fast rise, or we can change to from volume to pressure control mode, because in pressure control mode, the volume control mode, there is a constant flow is constant. It will not take care of the patient volume patient flow demand. And either we have to increase the tidal volume in flow control mode, and if we change to pressure control mode, it is a de-accelerating pattern, and will take care of the patient ventilatory demand. So the flow starvation, the better way is to change from volume control to pressure control, and we can if required, we can increase the flow from mild to moderate, or moderate to uh, high fast rise. And last resort, if then also the flow there is a flow asynchrony, we may need to restore give palliative. Cyclic asynchrony, either it could be delay cycle or early cycle. Means, so delay cycle. What is delay cycle? When ventilator TI is greater than patient's TI, delay cycle occurs. So in that, as the name signifies, delay cycle means ventilator cycle inspiration will stop and expiration will start uh, delay means it will start after the patient has already stopped inspiration and started expiration, and after that ventilator will start the expiration. So there is a delay in cycling from inspiration to expiration for the patient, and ventilator is different, and that is a ventilator is taking starting exhalation later than the patient. So this you will see on ventilator in a form of positive deflation. So as the ventilator is still giving positive breath, but the patient wanting to exhale it out, what will happen? The exhalation is a passive process, and patient it's a will try to exhale it out, so it will be deflated at the pressure time scalar as a positive deflation at the end of the inspiration. So you can see here. So what is the solution? Solution is to either we have to decrease the uh, TI time of the ventilator. For that, either decrease the tidal volume so that in lesser time now, because in as we know the volume control mode, volume is the cycle, so we have to decrease the volume so that cycling can occur earlier, and in pressure control mode, as we know time is the cycle, so we have to decrease the TI time, or we can increase the rise time by from slow rise to fast rise we can do. In pressure support mode, ex, uh, expiratory trigger sensitivity need to be increased. Suppose it is 10% of the peak inspiratory flow, we can 10% of the 60% of this, because inspiratory flow we can increase this to 60, so that instead of coming down from peak inspiratory flow 60, peak inspiratory flow it will come down to 60, and then exhale we can make it 10 or 20 or 30, so that it can exhalation valve can open at an earlier time, and the delay cycle can be corrected. So this you can see, this is a pressure support mode ventilation, and here we have increased the peak expiry trigger sensitivity. Here it is so low. Here we have increased a little, and here we have increased further. So this has now there is no asynchrony here. Premature or double trigger. Just now have in the beginning I have told you that we have to differentiate it double trigger from reverse trigger. So what is double trigger or premature cycle? As the name suggests, the ventilator TI is less than the patient TI. Means TI means inspiratory time. So we again in this we have to see the cycling. So in volume control mode we have to increase the tidal volume so that it TI time increases. In pressure control mode we can increase the TI by TI time, or we can slow the rise time. In pressure support mode, we can decrease the expiratory trigger sensitivity or increase the pressure support so that more tidal volume can be generated and more time for inspiration to TI time.